So moving right along. So now we can talk about neurotransmitters in a little more detail. Okay, so what do we say? Neurotransmitters are either excitatory or inhibitory, right? Okay, many can be both, depending on the location, right? All right. So we have different types of neurotransmitters. We have amino acid neurotransmitters, and these include things like glycine, glutamate, aspartate, and gamma aminobutyric acid, or GABA. Okay, so these are constructed from amino acids. We also have what are called monoamines. Okay, things like serotonin or 5-hydroxytryptamine, 5-HT. That is the chemical name for serotonin. Same thing. Dopamine, norepinephrine, and histamine are all examples of monoamines, right? These are structurally very similar to the catecholamines, and in some cases they are catecholamines like dopamine, norepinephrine, okay? And then you have these peptides, which are long chains of amino acids. These are proteins, things like substance P, the opioid peptides. Did you know that your body makes opioids, naturally makes opioids? And you have 3 different types, huh? Yeah, you actually have 3 different types of these opioid peptides. You have what are known as dynorphins, endorphins, and enkephalins. Right? Yeah, and everyone's, oh, I'm getting endorphins. Ah! And that's not what So what these things do is you have 3 general types of opioid receptors in your body. You have the kappa, the kappa, the mu, and the delta receptors. Okay, and these different substances activate different receptors. For example, dynorphins primarily activate the kappa receptors, where the endorphins, right, these primarily activate the mu receptors. And we know the mu receptor is a very important part of decreasing pain and even chemical dependency. And you guys, does anyone here run or do any like expedition kind of stuff? Used to. Yeah. What happens? So when you first start running, you feel terrible. You guys, you notice this? So when you first start your run, you feel awful. And then what happens is, as you get into the run, or a heavy workout or bike ride, what happens is you start to relax, you kind of start to lose yourself, and you just start feeling wonderful. And this is known as the runner's high, right? What's happening, in part, is your body begins to release endorphins. Those endorphins attach to the mu receptors in your brain and your spinal cord, and they decrease all of that pain that you were feeling earlier. That pain goes away, and then you kind of enter this bliss-like state, right? So it is in a sort of sense like you have ingested an opioid, right? You are having some of the similar effects, right? And so the opioid peptides are a very important part of pain response, right? Because if you are involved in a rigorous physical activity, evolutionarily that physical activity was either you're hunting, right? You're trying to get food, or you're being hunted and you're trying to prevent yourself from being food, right? Mm-hmm. In both cases, do you want your body worrying about mild or moderate pain? No, right? You don't want to worry about a cut on your foot or your finger when you're fighting off a lion or tiger on the savannas of Africa, right? That's not healthy. And so these are very important from an evolutionary standpoint as far as helping us survive and helping to protect us. Unfortunately, this system, in addition to the reward pathways in our brain, can kind of be hijacked, right? And it can be hijacked via ingesting or giving external opioids, right? And we know some of the problems that can lead to. So, what neurotransmitters do I want you guys to focus on? Glutamate. Glutamate is the most significant excitatory neurotransmitter in the central nervous system. And glutamate has its own receptors. a class of receptors known as the N-methyl D-aspartate receptors, or the NMDA receptors, right? And here's a question. Are there drugs that block NMDA receptors? Of course there are, right? A classic example of a drug that blocks NMDA receptors is ketamine. That's how ketamine works. It blocks these NMDA receptors, right? Which means that they cannot respond to glutamate, which means that the neurons get depressed, right? Because they're not able to respond to the major excitatory neurotransmitter in the brain, right? And then we talked about GABA. GABA aminobutyric acid is the most significant inhibitory neurotransmitter in the central nervous system, okay? And then acetylcholine is the most significant neurotransmitter of the peripheral nervous system, of the PNS. Very important. Okay. Remember I said that neurotransmitters can kind of have an inhibitory and excitatory role? I want to give you guys an example of that with glutamate. So we said that blocking glutamate receptors will prevent neurons from being excited by glutamate. You guys cool with that? Does that make sense? Okay. So you would think that if I give you something that blocks glutamate, you should become depressed, right? You should become depressed, right? Would that make sense? However, I'm betting, unless you're a little prude like me when it comes to some substances, I'm betting most of you have experience with a certain substance that blocks glutamate receptors in the brain. It's a legal substance, so we won't go down the illegal rabbit hole. Ethanol, alcohol, okay? One of the ways in which alcohol works, because we don't exactly know entirely, but one of the ways is it seems to block glutamate receptors. And that does account for what we see with people that take large amounts of alcohol, right? What happens? They get very depressed, right? Yeah, they have memory issues, right? And you can ingest, particularly with acute ingestions, right? You can ingest a large enough amount of alcohol to quit breathing, right? To lose airway, right? So it does, but what also happens with alcohol, ethanol ingestion? Yeah, but we're talking about the brain. Does it always cause people to become depressed and quiet? No. What also happens? Yeah, so this is interesting. So what happens is some of the areas in the brain that get depressed first are areas that are involved in self-control, higher thinking, planning, self-regulation, right? So what happens is, so again, this alcohol is depressing the brain, guys. It's depressing the brain.
But it's depressing parts that will inhibit.
It is depressing parts of the brain that are responsible for self-control and things like that. So what happens is those parts get depressed, which means the parts of the brain involved in acting out and disinhibition and things like that rise to the surface, right? So even though alcohol is depressive and it is blocking glutamate receptors, you can still see people get excited, right? And belligerent and violent, because it's not because they're being excited by the alcohol per se, it is because the normal inhibitory mechanisms in their brain are being depressed, right? Now, as you add more and more and more and more alcohol, eventually those areas will become depressed, right? And then the patient will eventually become depressed. Of course, they can develop tolerance and things like that, but does that make sense? And that also makes sense why, and this is something you guys run into, right? Which is a very important thing for you guys to know. In general, withdrawal from substances, drug withdrawal, in general is not life-threatening, right? If you try to withdraw, like let's say I snort 3 lines of Coke a day, right? I'd probably be a little thinner than I am now if I did that, but, right? If I, huh? Yeah, yeah. That's my problem is I'm that typical type A EMSer, right? If I'm gonna do something, I'm gonna do it, or I'm gonna go hard. So, yeah, yeah. But anyway, if I stop doing cocaine cold turkey, guess what? I'm gonna be uncomfortable. I'm gonna be crabby. I'm gonna be mad. I'm gonna miss all that cocaine, but I'm not gonna develop seizures, hallucinate, puke all over myself, and die of circulatory collapse, right? It generally doesn't happen. How, huh? Yeah, you can get depressed. You can feel terrible, bad, awful, all that, but it's not acutely life-threatening, right? Like you're not gonna hallucinate, have a seizure, and your blood pressure bottom out, right? That generally doesn't happen. However, we know that alcohol withdrawal, acute alcohol withdrawal, is life-threatening, right? Yeah. Acute alcohol withdrawal is a life-threatening emergency. If you come across a patient that has a history of heavy alcohol use and or abuse, and they have stopped for whatever reason, and they are going into withdrawal, you should treat that as a medical emergency, right? Delirium tremens is a medical emergency. Why is that? Well, what happens is, in somebody that drinks lots of alcohol, their brain gets used to all those glutamate receptors are blocked by the alcohol, right? And so the brain is in kind of this constant state of being depressed, right? And if you stop that alcohol, what happens? It goes away. All those glutamate receptors open up, and now all that glutamate that the brain's been making can then attach to those receptors, and what happens? Patient starts having seizures. They start hallucinating. Their blood pressure gets high and low, and just things go crazy and off the rails, right? Does that kind of make sense a little bit? And so you can see how we're already starting to develop some idea of the basis of some of these neurological problems by just talking about these things. And we know what is one of the primary drug classes that we use to treat alcohol withdrawal. Yeah, thiamine for other reasons, but what do we use, huh? What is like the primary agent that we use to get these people through the acute withdrawal, that control those seizures, control those hallucinations? So it's an excitatory neurotransmitter problem, so benzos, right? So we make use of the inhibitory, GABA, right? So we give these patients large doses of benzos in some cases, right? To allosterically help with the GABA, right? The GABA receptors to help depress all that activity. Does that kind of make sense?
When something's blocked, your body doesn't necessarily stop making it.
Right.
So when it finally becomes unblocked.
Yeah. So you have all these nice, fresh receptors that haven't had to deal with glutamate, and now all of a sudden all this glutamate's attaching to them. And it just goes off the rails. That's why alcohol withdrawal can be so life-threatening. And let me ask you the next question. So, going back to inhibitory, excitatory neurotransmitters, can you think of another class of drugs that can present with a life-threatening withdrawal syndrome other than alcohol? And it involves this. Actually, no. Opioids tend not to cause benzodiazepines. Yes, benzodiazepine withdrawal. Because it's GABA that we're talking about, right? Is a patient that cannot respond normally to inhibitory neurotransmitters, right? And you take all that away, right? And now you have an overactivated excitatory response. So withdrawal from benzos, right? If somebody takes 3-4 Xanaxes a day and then they quit, they go cold turkey on their Xanax, they could have a life-threatening withdrawal from benzodiazepines. Yeah. So ethanol, benzodiazepines tend to be the most life-threatening, and then opioids can be life-threatening in some cases.
So what would they give for benzo?
What, benzo withdrawal?
Mm-hmm.
Benzos?
Just moderate.
Yeah. So with benzo, you don't withdraw from benzos. You wean off slowly. Yeah, you wean off slowly, right? Yeah.
You do that with alcohol loaded too, don't they?
Yeah, there are lots of things that can be done with alcohol. Huh?
I've seen where like they'll have an order for them to bring a couple beers to them.
Yeah. Well, and interestingly enough, like, I actually experienced this when I was in nursing school. It was a patient that needed to have open heart surgery, and it was like a 6-7 hour surgery that they needed to do. He was a cabbage, and he was an alcoholic. And so, what do you think happens during the surgery? He's not drinking, right? Goes into withdrawal. They die. So what they actually did is they actually infused ethanol into this patient during the surgery, an ethanol infusion, to keep his alcohol levels up, to prevent him from going into acute withdrawal.
There was a orthopedic surgeon in Roswell, I heard, that had to do that one time because he had a patient that was such a severe alcoholic.
Yeah. And we forget that, right? Cigarette smoking is another one. It's now cessation from smoking is not life-threatening, but it's not uncomfortable. Yeah, it's uncomfortable. And honestly, one of the things that we look at in patients who get hospitalized is, are they a smoker, right? Because if you're going to be in the ICU and you're a smoker, you're not going to be smoking. But you're going to start withdrawing, right? And you're going to have blood pressure changes. You're going to have heart rate changes, and we may not want those changes. If let's say you're a cardiac patient, we may not want those changes occurring. So what should we be doing? Yeah, get them on a nicotine patch. Yeah, absolutely. Okay, so you guys good with that? So far, so good? So I know that I'm not specifically talking about disorders yet, but we're already starting to understand the basis of some of these disorders and how and why we treat them, which I think is so fascinating. Okay, let's move along. All right, so what I want to do now is I want to talk about the receptors for some of these neurotransmitters. And there are two general types of receptors. There are what we call ligand-gated ion channels. These are also known as ionotropic receptors. Ligand-gated ion channels are ionotropic. These are channels that either open or close and allow ions to go in or out of the cell. In this case, we're talking about the neuron. And an example of that would be the GABA receptor, right? The GABA receptor is a chloride channel, and when it's activated, it lets chloride flow into the cell, and that hyperpolarizes and depresses it. Now, there is another type or class of receptor known as a Gprotein coupled receptor, also known as a metabotropic receptor. And that the way this one works is very different. So an ion channel, a ligand-gated, and a ligand is just something that attaches to something else. So in this case, the neurotransmitter acts as a ligand, it attaches to the channel, and it's kind of like that lock and key analogy that you learned in pharmacology. It either unlocks it or locks it. It's not really what happens, but that's an analogy we can use to form the basis for understanding this. The Gprotein coupled, or the metabotropic receptor, is very different. An example of this might be a beta-2 receptor for norepinephrine and epinephrine. That is a classic example of a Gprotein coupled receptor. So what happens with the Gprotein coupled receptor is your neurotransmitter acts as a ligand, it comes in, and it attaches to the receptor. And this here is the cell membrane. So this is extracellular and this is intracellular. And this receptor is coupled to this protein here on the inner surface of the cell. Do you see that there? This is called a Gprotein. And this Gprotein has different subunits. It has an alpha and a beta subunit. And what happens is when this receptor gets activated, these subunits dissociate. They break apart, and they go on to activate other pathways inside of the cell. Okay? And one of the major things is an enzyme called adenyl cyclase, which is activated by the beta unit. And when that adenyl cyclase gets activated inside of the cell, it's an enzyme that gets activated, it causes the creation of other molecules known as secondary messengers. And then those secondary messengers go on to modify processes occurring within the cell. One of the most common secondary messengers we run into is something known as cyclic 3'5' adenosine monophosphate, or CAMP for short, CAMP. And in the case of the beta 2 receptor, the increase in CAMP, prevents smooth muscle from constricting, which causes smooth muscle in the bronchioles to relax and dilate, right? That makes sense? So it's a bit more complicated, and it involves Gprotein activation and adenyl cyclase activation and intracellular messengers and signaling to occur. Okay. So how do I terminate? So how do I terminate this, right? So the neurotransmitter gets released, but how do I reset things within the synapse? Well, there are a few things. I can use enzymes to degrade the neurotransmitters. And some examples of that might be an enzyme known as monoamine oxidase, or MAO. Okay, monoamine oxidase oxidizes monoamines. So these guys here, right, serotonin, dopamine, norepinephrine, epinephrine, histamine, are all deactivated by monoamine oxidase, right? It oxidizes the neurotransmitter and deactivates it, okay? Acetylcholinesterase, you guys should be familiar with that. Acetylcholinesterase is an enzyme that deactivates acetylcholine, right? It catalyzes the breakdown of acetylcholine into choline and acetic acid, right? Through hydrolysis reaction, hydrolyzes. And in general, hydrolytic reactions in the body are breaking things down, and then dehydration reactions are involved in building or synthesizing. But anyway, the other way that we can terminate neurotransmitter action is by what's known as reuptake. That is, the neurotransmitter gets pumped back into neurons, or in some cases the glial cells. So it gets pumped out of the synapse, back into the neuron or into the glial cells, where then the neurotransmitters get recycled, right? For example, your norepinephrine and dopamine have transporters that transport them back into the neurons that release them. And one of the problems with substances like methamphetamines, you guys are familiar with methamphetamine, right? Why methamphetamines can be so nasty is methamphetamines attach to these transporters and cause the transporters to basically invert themselves, right? And so instead of causing reuptake of dopamine, norepinephrine, epinephrine, the transporters kind of re-invert themselves and then spew out all that norepinephrine and dopamine back into the synapse. So when you take meth, it causes all this norepinephrine, epinephrine, and dopamine to spew out instead of get sucked back in, or instead of undergoing reuptake. Does that kind of make sense? Serotonin also has its own transporter, and there is a whole class of drugs that take advantage of this, and these are known as the selective serotonin reuptake inhibitors, or the SSRIs. You guys familiar with those? And the SSRIs block the serotonin reuptake channels, and that causes an increase of serotonin in the synapse. And we know that when we increase serotonin, we might be able to treat some of the signs and symptoms of depression in some patients, right? And that's how the SSRIs work. Obviously, you're increasing serotonin levels, and that's not without its risks, right? What's that? Or can cause overexcitation as well. And in some cases, it can cause an increase in suicidality, particularly in kids. We actually see this in kids who are placed on SSRIs. And we think one of the hypotheses is that it might be just due to people getting a little more energy, right? Has anyone been like profoundly depressed? Maybe, hopefully. Shocker. when you get profoundly depressed, it's interesting. People that are just super profoundly depressed may not be at a very high risk for suicide. Why? So they're so depressed that they're just not capable. Yeah, they're not capable of following through. They're just not, right? And so what can happen is in some patients is as you treat them, as they begin to get more energy back, they will be more capable of thinking of a plan, developing a plan, and acting on it. What's that? Dreaming about it? Yeah. Okay.
So with alcohol and severe depression, that's where you can possibly increase?
Yeah, you sure can with alcohol. Yeah, alcohol use. Yeah, you sure can.
You can have well and try and drive drunk, that's pretty much.
Yeah, that'll do it too. Yeah, through traumatic mechanisms. All right. Cool. And we know there's also a class of medications called the MAOIs, monoamine oxidase inhibitors, that inhibit the MAO enzyme, which causes monoamines to increase, and that has led to a class of antidepressants known as the MAOIs. Obviously, though, if you're increasing catecholamine levels in your body, there are side effects, right? Blood pressure is going to increase, right? Heart rate's going to increase, right? So you can have some problems there. Okay. Woo, boy. Okay. Cranial nerves. So, actually, you know what? It is 11. Let me get you guys on a break. Take a break. And away we go. All right, so what I want to talk about now, I'm going to talk about some of the nerves that come directly off the brain. These are known as the cranial nerves. And you have one that comes out of each side of your brain, so we call pairs of cranial nerves, right? We have what are called 12 pair that come directly off the brain. Directly off the brain and exit via forama. Forama are little holes. So you have little holes throughout your skull, and the big skeleton has disappeared, but I'd point a few out. But you have these little holes in your cranium, and those holes are typically where those cranial nerves come in and out, and of course blood vessels as well. All right? And these cranial nerves primarily innervate, and innervate just means that a nerve goes to a certain area of the body. Innervation. Innervate the face, the neck, and the superior part of the trunk. All right? With the exception of the vagus nerve, and it is the primary nerve of the parasympathetic nervous system, and it goes, everywhere. So, how do we memorize the 12 cranial nerves? There is an old saying. On old Olympus towering top, a Finn and German viewed some hawks. Okay, that is the classical, that's how I learned how to do it in anatomy and physiology. There is a more contemporary way of memorizing the cranial nerves. However, it's not appropriate. I can't say it. But I can start it, and then you guys can Google it, and I'm sure it'll pop right up, right? It starts off with O to touch and feel ... So go to Google, type that in, O to touch and feel, cranial nerves, and you'll get the full thing, right? You'll know exactly what it's all about, okay? That resonates with you, go ahead and use it, okay? But let's talk about the cranial nerves individually, and we're going to start from the uppermost, the most superior, and then we're going to work our way down to inferior, okay? So the uppermost cranial nerve is the olfactory nerve. This is entirely sensory, and this is our sense of smell. All right? So our sense of smell is a cranial nerve, comes directly out of the brain. All right? Next is the optic nerve. This is all sensory, and this is our sense of vision. All right? So we've got olfactory, optic. The next cranial nerve number 3, is the oculomotor, and this is primarily a motor, okay, not sensory. So this is efferent. And this primarily innervates the pupils, okay? And this is the nerve that we are assessing when we use a pen light to assess the pupils, right? What we call the ocular movements. And you guys should have learned how to do neuro exams in your intro course, right? And you know when you are doing you're looking into somebody's eyes, there are two movements that you assess. You assess the ocular movements and the extraocular movements, or the EOMs, right? And the ocular movements are the pupils themselves. Extraocular tend to do with the eye, or the globe of the eye moving itself. All right? And we know that anything that puts pressure on the oculomotor nerve will cause the pupil to dilate. And so when we see pupillary dilation, this tends to be an ipsilateral finding. What does ipsilateral mean? When I say the term ipsilateral, what does that mean? Ipsilateral means on the same side. So if somebody has a head injury or some sort of head problem, they have a dilated pupil, dilated unresponsive pupil, that generally means that the problem is on the same side as the deficit.
So left-sided dilation.
The problem is stemming from the left side. That's what we mean by ipsilateral. But we know that when it comes to the brain, motor pathways and some sensory pathways decussate. Okay, there's a term called decussation. Decussation means to cross over. The pathways cross over, okay, in and around the pyramidal tracts of your spinal cord. So what that means is that motor information that comes from the left side of your brain crosses over as it goes through the spinal cord and innervates the right side of the body, right? So if somebody has damage to, say, the motor cortex in the left side of their brain, they will likely have a deficit to the right side of the body, and that is known as a contralateral deficit, right? Does that make sense? So you have contralateral and ipsilateral deficits, but oculomotor nerves tend to be ipsilateral. The next one, cranial nerve number 4, is a trochlear nerve. This is mainly motor, and this innervates the superior oblique muscle of the eye, so this is involved in motion of the eye itself. Okay? Then we have what's called the trigeminal nerve. This is mixed motor and sensory, and there are 3 divisions of the trigeminal, i.e., that's why we call it the trigeminal. You have the ophthalmic division, which goes to your scalp, your forehead, your eyelids, and your tear glands. Okay, so the uppermost, the most superior. Then you have what's called your maxillary division, which innervates the maxilla. What is the maxilla? Where is that located? It's the superior part of your jaw, right? Up here. And that innervates the upper teeth, okay, the palate. And then you have the lower part of the trigeminal, the most inferior, that is the mandibular division, the mandible, okay, and that's primarily involved in mastication or chewing, right? The masseter muscle of the jaw. And there is a disorder known as trigeminal neuralgia, fairly common, also known as tic de la Rue. And this is a chronic, painful condition that involves damage, inflammation to the trigeminal nerve, and typically these patients tend to have attacks that kind of come and go, and they can have all sorts of, they can have pain, they can have motor problems, tearing, something called blepharospasms, or spasms of the eyelids and pains and all that. It can be very painful and sometimes be kind of hard to manage. Okay, so the next nerve is abducens. All right, so we've talked about 1, 2, 3, 4, 5, and now 6, the abducens nerve. The abducens nerve is primarily motor, okay, and this is primarily the lateral rectus muscle of the eye, right? So the trochlear and the abducens nerves are very important when it comes to extraocular movements, the EOMs. All right, cranial nerve number 7 is the facial nerve, and this is mixed motor and sensory. And it includes taste, facial expressions, tearing, salivary glands, and the facial nerve is the nerve that is involved in Bell's palsy. And we've already talked about Bell's palsy. That is the nerve that is involved with Bell's palsy. So do not confuse Bell palsy with trigeminal neuralgia or tic Delarue, right? They're different things. Different nerves are involved. The next nerve, okay, is known as the vestibular cochlear nerve or the auditory nerve, right? And this is 8. And this is primarily sensory, and this is hearing and balance. So this goes to your ear, okay? It goes into the cochlea, all right? Cranial nerve number 9 is the glossal pharyngeal. This is mixed motor and sensory, and this is involved in swallowing, innervating the tonsils, and the posterior part of the tongue, so the back of the tongue. Okay, a super important cranial nerve, the vagus nerve, which is again mixed, and this is the primary nerve of the parasympathetic nervous system. All right, you need to know that. And in some cases, we will cut a branch of that nerve with people that have certain gastrointestinal disorders. For example, if they have an ulcer, and that ulcer perforates and they need to go in and repair it, one of the things they may do is they may cut the branch of the vagus nerve that goes to the stomach, and what will that do? That will prevent acid secretion, right? It'll decrease the acid levels in the stomach. And that makes sense. Why? Because what branch of the nervous system causes us to secrete stuff? The parasympathetic, right? So you're cutting the parasympathetic nervous system off from the stomach. All right? The spinal accessory nerve, or some people call this the accessory nerve, is mainly motor, okay? And this is primarily assessed by the ability to shrug. Right? Asking your patient to shrug. Can they shrug? Right? And then finally, the 12th cranial nerve is the hypoglossal nerve, not to be confused with the glossal pharyngeal, all right? But it does innervate some of the same areas. So mainly motor, innervates the tongue, and it allows for speaking, right? Your tongue moves around in your mouth and allows you to phonate or speak properly. Also helps us with chewing and swallowing. Cool. You guys okay with that? Those are the 12 cranial nerves. You're going to have to memorize them. I'm sorry. It's kind of a tedious exercise, but to touch and feel will get you a long ways in memorizing those nerves. You should definitely focus on the most important ones, right? You should know, for example, what the oculomotor, right? You should know olfactory, optic, oculomotor, right? Vagus, very important, right? Because they have important medical implications for us. All right, just to review the anatomy of a peripheral nerve, right? So these nerves are coated in what's called epineurium, right? That's the outer portion, outer covering, connective tissue. And then you have little bundles called fascicles. So this is very similar to how muscles are arranged, right? And then those fascicles are covered in what's known as perineurium, right? And then you cut into the fascicles and you have the axons, the individual axons of the individual neurons themselves, and those axons are coated in another protective tissue called endoneurium. So endoneurium covers the axon, perineurium covers the fascicle, epineurium covers the entire nerve. So when we say a nerve, when we're talking about the peripheral nervous system, a nerve is not an individual neuron. A nerve is a large bundle of structures, right, that contains many different axons, thousands and thousands and millions of axons that go to neuron bodies somewhere else, either in the central, in the brain or spinal cord. And then finally, the neurons themselves, which are typically coated with myelin in the peripheral nervous system. Not all, but some are. You guys good with that? You guys hanging in there okay? So far so good? All right. Moving right along. Oh my goodness. What have we here? All right, well, let's Oh no. All right. Okay. So let's talk about spinal nerves now. Maybe I can. I'm trying to make this stuff smaller. There we go. There we go. Is that a little better? You can actually see it a little better there? Yeah. Okay, cool. All right, guys. So, we talked about cranial nerves. Now we're going to talk about spinal nerves. And we have 31 pairs of spinal nerves. And you remember the spinal column, the different vertebrae? Right, you have 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. And the sacral and the coccygeal are all fused together. Okay? And these spinal nerves are mixed motor and sensory. Okay? And so here I'm looking at a cross-section of the spinal cord itself, right? And in the very middle of the spinal cord, you have what's called the central canal. And the central canal is filled with cerebral spinal fluid, circulates through the central canal. And the spinal cord is also covered in meninges, like the brain, because it is a part of the CNS, all right? And then what you have these nerve roots that come out of the front and the back of the spinal cord, okay? And you have what's called a dorsal root, and a dorsal would be the back, right? Dorsal fin, the posterior. And then you have what are called ventral roots that come out of the front, or this anterior part. So this is anterior here, and this is posterior here, or dorsal and ventral. And primarily sensory information comes out of the dorsal root, or goes into rather. So sensory information comes in through the dorsal root, and motor information comes out of the ventral root. You guys okay with that? And then you have interneurons within the spinal cord itself that can help communicate some of those back and forth. Okay, you guys okay with that so far? Okay, we'll go into this in a little more detail in trauma when we talk about spinal cord injury syndromes, because this does give rise to syndromes. Okay, you also have different colored, if you were to look at the cross section, okay, you have this inner part of the spinal cord, which is darker, and we call that gray matter, right? And then you have this outer part, which is white in color, and we call that white matter. And we also see this in the brain as well. Gray matter is composed of the cell bodies, neuron cell bodies, and then white matter is primarily composed of axons. You're looking at the myelin. Myelin's kind of fatty. Okay, so anywhere you see white matter, you have axons going around making connections. So you have the pathways, and then anywhere you see gray matter, okay, darker areas, that's where you have the actual cell bodies themselves that are integrating and processing information. Does that kind of make sense? And you see that in the brain as well. This gives rise to a concept known as a dermatome. What is a dermatome? Dermatome is a map of the body, and then at different points you can map on where in general the spinal nerve is, right? And you guys probably learned about these in trauma when you went through your basic or intermediate courses, right? And you learned to mark where the patient loses sensation. And wherever the level of that marking is, that indicates where their injury might be, right? That's called a dermatome map that we use. Some important dermatomes that you guys might want to focus in on. See if I can make this smaller. It's all messed up. Okay, well, that'll work. I wish I could move this now. So T2, or the second thoracic vertebrae. Okay, T2 is at the apex of the axilla. the very top of the axilla, right? So that is approximately the T2 dermatome, right, where those spinal nerves come out. T4 tends to be at the nipples, right? So those are two kind of important dermatomes, and there are a few others, but you can review them in your reading. Okay, so far so good, guys? All right, well, moving right along. Now what I want to do is I want to take a look at the brain itself, all right? The brain in general can be divided into two general sections, the upper part and the lower part, all right? The outermost part, or the uppermost part, is known as the cerebrum. And the cerebrum sits on top of what's known as the midbrain and the brain stem. And in general, the lower you go into the brain, the more dinosaur-like, survival-like, animalistic centers you run into, okay? For example, your brainstem, there's no conscious stuff going on in the brainstem, right? It is all, right, respiratory centers and cardiac centers, vomiting centers, right, protective reflexes, and cardiorespiratory centers. And then as you go higher and higher into the brain, you have higher levels of cognitive functioning occurring until you get to the very front, your prefrontal cortex, where you have, right, personality, planning, memory, higher level cognition. Does that kind of make sense? So in a certain sense, your lower parts of your brain can be thought of as like your animal brain, like your dinosaur, your lizard brain. And then the upper part can be thought of as kind of like an intellectual Einstein, right? And it is the evolution of the upper part of our brain that has kind of allowed us to push, to some extent, those animal, quote-unquote, instincts down, if you will, and allow us to do things like plan, right? And that is one of the things that separates us from other animals, right? If you think about it, you all have dogs. Some of you have dogs or been around dogs. Have you ever seen a dog make a plan? Like, hey, I'm gonna take a walk. I'm gonna pencil that into my calendar for next week, and let's do that, right? We don't see animals making plans like that, right? They're very in the moment, right? A dog is very much in the moment kind of living, right? As long as it's doing stuff, it's pretty happy, right? As long as it's not sick, you're doing stuff. It's cool. It's happy. It doesn't really care about what's going to happen 3 weeks from now, right? Human beings are a little different than that, right? Planning is a very important part of what it means to be human, and we couldn't do that without a highly evolved upper part of our brain. And we see that animals that have less and less development there tend to be more and more, quote-unquote, animalistic, right? Like alligators, for example. Alligators and crocodiles, what are they? They're just eating machines, right? And then you have human beings, which sometimes can be not necessarily animalistic eating machines, but we can. Okay. All right. So that's a general way of looking at it. Now, the cerebrum itself is divided into what are called lobes, right? And when we look at the outer part of the brain, the cerebrum, it is bumpy and folded. And you guys have all seen pictures, and there are pictures in your book. It's bumpy and folded. And those folds go in and out, and what they do is they increase the surface area of the brain, right? They increase the surface area. And that outer part is known as the cerebral cortex, right? And so you have these hills, these hilltops, okay? You have these hilltops, and then you have these little valleys. And the little valleys are known as sulci, or a sulcus when we talk about the singular one. And then the little bumps, the little hilltops, are known as the gyri, or a gyrus. Okay? And then a very deep sulci is known as a fissure. Are you guys good with that? Kind of makes sense? Okay, cool. So what we have here is you have, on the top of the brain, you have a very deep sulcus, a fissure here, known as the central sulcus. I'll outline it right here. All right, it's a very deep fissure. And that divides the two major parts of the top part of your brain. That divides the frontal lobe here and the parietal lobe here. You guys cool with that? And there is a bump, there is a gyri that forms a strip in front of that fissure, that sulcus, and then there is another strip, a bump, behind that. Okay, the bump in front of it is known as the precentral gyrus, and the one behind it is known as the postcentral gyrus. And these are important because the precentral gyrus, which is in the frontal lobe, the very back of the frontal lobe, is known as the motor cortex. That is your motor cortex. That is where a significant amount of motor information leaves that, okay? And that is where, when we talked about ALS earlier, and that you lose motor neurons die, that area is primarily involved. When you lose motor neurons, you're unable to have motor control, right? You lose the ability to have motor control of your muscles. Now, behind that, in the postcentral gyrus, is known as the sensory cortex. So that is sensory information in the very front of the parietal lobe. So motor and sensory information, motor and sensory processing occur in different areas of the brain. Does that make sense? And they are separated by this deep sulcus. You guys cool with that? All right, so I wanted to point that out. So you've got your frontal lobe, you've got your parietal lobe, and then the very back of the brain is your occipital lobe. That's primarily where we have visual processing occurring. And then inferior to that, you have what's called the cerebellum, little brain-like structure that hangs off the back. It is inferior to the occipital lobe, okay? And that is where fine motor coordination occurs. We know that damage to the cerebellum can cause loss of fine motor coordination and can cause what's known as ataxia, or that shuffling ataxic gait. And probably most of you have poisoned your cerebellum at some point in your life, right? And what would you poison your cerebellum with? Alcohol, ethanol, that would cause ataxic gait. That's where that quote-unquote drunk walking comes from, is poisoning neurons in the cerebellum. You guys good so far? All right. Now, on the side of your brain, around the temporal bone, you have what's called the temporal lobe. And the temporal lobe is very important when it comes to what? When it comes to hearing, hearing, auditory, reading, and some language processing. Very important areas. So far, so good? Okay. And we'll talk about the inner part of the brain here in a little bit. Now, there are a couple areas I want you guys to note. And right here, okay, in the temporal and part of the frontal lobes, okay, so the upper part right in here of the frontal lobe, the middle part of the frontal lobe, and near the temporal lobe is an area known as Broca's area. And Broca's area is involved in expressive speech. So this is the area of the brain that allows me to say words to you guys, or to express thoughts, concepts, and ideas that you can actually understand. And if that area gets damaged, that will lead to something known as expressive aphasia. And what is aphasia? Difficulty speaking, right? Yeah, or communicating, aphasia. So if I have damage to Broca's area here, I can understand, right? I know what I want to say, and I can understand you as you're talking to me, but I cannot get that out. I cannot get that out in an intelligible manner, right? Now, there's another area back behind here in the temporal lobe called Wernicke's area. And Wernicke's area allows us to receive speech and understand it. So there's a separate area of the brain. This is weird, isn't it? You'd think speech would occur in the same area, right? No. Okay, Broca's area is the ability to express. Wernicke's area is the ability to understand. So if I have damage to Wernicke's, I can't understand what people are telling me, even though I can express fine. Isn't that weird? It's really odd. You'd think it'd be all together, but it's not. And damage to this area can cause something known as receptive aphasia. You can't receive information, right? And this is important because there is a disorder known as Wernicke's encephalopathy that can occur. And we see this primarily in people who are very malnourished, right? So they've been in a long period of starvation, for example, or they're severe alcohol or substance user and they're not eating well, they're not getting good vitamins in their diet, or they're real brittle diabetic or something like that, where they're not getting thiamine in their diet. And what can happen is if you have low levels of thiamine and you get a bunch of sugar, you're not able to process that sugar appropriately, and that can cause damage to Wernicke's area and can cause Wernicke's encephalopathy. And so that's why thiamine is a medication that we often need to consider giving somebody who may be chronically malnourished, to prevent Wernicke's encephalopathy from developing. And it is, by and large, irreversible. They go on to develop that. You guys cool with that? Okay, so a couple more things. Approximately 75% of all the neuron cell bodies in the nervous system are in the cerebral cortex, the outer part, right? And the cerebral cortex, like the spinal cord, is divided into gray and white matter. The outermost part of the cortex contains the gray matter, so all the cell bodies are on the outside. And then the innermost part contain all the axons, and that makes sense, right? You have your cell bodies, and then they can communicate with other areas. And so what you're seeing with that white matter are the axons, and then you're seeing the cell bodies. You guys cool with that? So far, so good? Okay. Also, deep within the brain, you have what are called your ventricles, right? You have 4 of them. You have 2 lateral ventricles. You have the 3rd ventricle, and then underneath that you have the 4th ventricle. And then that drains into a little canal called the cerebral aqueduct, which eventually becomes the central canal of the spinal cord, and that, of course, is filled with cerebral spinal fluid as well. So far, so good? Okay, so that's the outer part of the brain. So moving right along. We're going to keep going until about noon. Now I'll put you guys on a little break. So now what I'm going to do is I'm going to cut the brain in half. I'm going to cut what's called a sagittal view of the brain. And when we do that, we notice something very interesting. So here's the cortex up here. And the cortex, you have a portion of cortex on the right side, a big portion of cortex on the left side, and then you have this strip of tissue here of white matter that is in between those, and that's known as a corpus callosum. And the corpus callosum actually connects the 2 hemispheres. So the brain is, not only is it divided into individual lobes, but it's divided into hemispheres. It's divided into a general right side and a general left side, a right and left hemisphere. And then those hemispheres communicate through the corpus callosum. So if you were to cut or damage the corpus callosum, the right side of the brain would have a hard time communicating with the left side and vice versa. And there are actually patients that have surgery called split brain surgery. Tends to be really severe seizure patients where you'll cut through the corpus callosum. And that can produce some really weird side effects. And they only really present when we isolate the right and left side of the brain. And there's some really cool videos on YouTube. One I saw was where they had a patient look into a projector, and they had a lens in one eye and a lens in the other eye, and they projected different images. And I forget which side, but they projected like crosses and pictures of Jesus and real religious images. and the person had a real religious experience, like, oh yeah, I'm a Christian, this and that. And then they did those same images in the other eye, and the patient's like, what is that? That's silly. I don't believe in God. This doesn't make sense, right? And so literally one hemisphere was kind of atheistic, and the other part was very theistic. And they were able to produce those separate responses because normally both hemispheres would be able to communicate, and they weren't able to. And there are lots of other weird things that can occur when that happens. Pretty cool, isn't it? I mean, it's really interesting. Underneath the hypothalamus, it sits on top of the brainstem, there's something called the diencephalon. And the diencephalon contains the thalamus and the hypothalamus. Okay? And the thalamus is a relay center. It is a relay center. It's like a switchboard that relays information to and from the upper and lower part of the brain. So it's like the gatekeeper of the upper and lower part. Okay? The hypothalamus sits right underneath it, right? We know is very important when it comes to anger, sexual response, thermoregulation, right? Thermoregulatory centers are in your hypothalamus, and the hypothalamus gland is the major control center of the endocrine system, which is why next week endocrinology will follow right after neurology, because the nervous system is in direct control of the endocrine system. It's actually an extension. The endocrine system is actually an extension of the nervous system, and it all begins at the hypothalamus there. Okay? And the pituitary gland is an extension that hangs off the hypothalamus at about the level of the optic chiasm where the optic nerves cross over. Okay? You guys good with that so far?
Does it cross over underneath or above?
On top of the, yeah, so the, above or superior to the pituitary gland, and the pituitary gland kind of hangs down.
Okay.
Yeah, just, it's a little tiny pea. It's tiny, yeah. All right, some other structures associated with the diencephalon include the amygdala and the limbic system. These are near the diencephalon, and these are very important when it comes to the emotional response. And interestingly enough, there is an emerging therapy for PTSD, for treatment-resistant PTSD. It involves a medication called methylene dioxymethamphetamine, or MDMA. All right, this is the active compound in what is known as ecstasy. Ecstasy is the street version of it, which may not be pure MDMA. And there are several trials that have been done through the VA, the Veterans Administration, on patients with PTSD that's treatment resistant, and they will give them MDMA, and then they will do intense psychotherapy on them under the influence of MDMA. And what we find is MDMA suppresses activity in the amygdala, and we know the amygdala is very important when it comes to the fear, anger, response. And so what we do is we take these people that have this exaggerated fear response, and we suppress that. We give them the MDMA, we suppress that, and then we do psychotherapy, and we bring them back through that experience, that traumatic experience. And because all that negative stuff is suppressed, it's just positive emotional, and they can reintegrate that experience into the frontal lobe of the brain. And then after the effects of the MDMA have worn off, they have, in essence, moved that experience into a higher part of the brain. And I think some of the success rates are near 90%. 90% cure rate after 3 sessions. And so this is actually moved into phase 3 clinical trials, which is large, right? That's the last hurdle for FDA approval, right? So interesting. And it has direct neurological tie-in. It is, yeah. And it's already in phase 3 trials. Yeah, it is in phase 3 clinical trials are starting. It makes it through phase 3, and it will become an FDA-approved substance. It will be descheduled. Right, it'll probably be like a Schedule 2. Yeah, that's another story. But yeah, anyway, here we go. You guys good with that? Good. And part of this is the limbic system is also kind of involved in that as well. Okay, let me get you guys on a break. Okay, here we go. Picking back up. So this should go pretty quick. Talking about the meninges. Are you guys okay with the meninges? Should be the structure of the meninges. Just remember the meninges form a pad of protection around the brain. So here I have the parenchyma, the parenchyma of the brain, and I have the very delicate matter that is almost indistinguishable from the outer part of the brain, known as the pia mater, right? And then I have the arachnoid membrane, which is on top of the pia mater, and then I have what's known as the dura mater, tough mother, right? So pad, right? Pia, arachnoid, dura. And then I have a space in between the brain, in between the pia mater and the arachnoid, and that's known as a subarachnoid space. And the subarachnoid space is filled with cerebral spinal fluid, right? Circulates around the brain. So you have CSF around it as well as within it, in the ventricles. All right. And then on top of the arachnoid is the dura mater, and you have bridging veins that actually connect the dura to the arachnoid. And so we know that damage underneath the dura can sometimes lead to venous bleeding, known as a subdural hematoma or subdural bleeding. And typically bleeding underneath the arachnoid matter is arterial, and that's known as subarachnoid hemorrhaging, right? And then you can also get bleeding between the skull and the dura mater, and that is known as epidural, right? Or on top of the dura. And this is known as an epidural hematoma, right? And this tends to be arterial bleeding, tends to be an artery on the outside of the brain known as the middle meningeal artery, and tends to be the result of injury over the temporal bone. The temporal bone gets injured, or force comes through that can compromise the middle meningeal artery and cause an epidural hematoma. Epidural hematomas tend to develop pretty rapidly, right? Rapid onset signs and symptoms. And they have that classic or that characteristic lucid interval, where you have an initial loss of consciousness and some return of consciousness followed by a rapid decline. And you can also get bleeding within the brain itself. Okay, what is meningitis? Infection or inflammation of the meninges, right? And there's a triad of findings with meningitis: fever, headache, and stiff neck, right? Those are classic findings associated with meningitis. There are also classic findings associated with subarachnoid hemorrhaging. Subarachnoid hemorrhage can present very similar, and in some cases indistinguishably, from meningitis, all right? And there are two signs that I want you guys to be aware of. These are known as Koenig's sign and Brzezinski's sign. Okay? These are for detecting meningitis or meningeal irritation, right? So if your patient is lying supine, they're going to have limited hip and knee flexion, right? So what does that mean? What does it mean to flex your hips and your knees? Yeah, right. It's going to hurt for them to do that. Why? Because it's stretching meninges. That is known as the Koenig sign. Okay? The Brzezinski sign is limited neck flexion, right? So they will not, that's that typical, we call nuchal rigidity, or that neck stiffness. Okay, cool. You guys good with that? Okay, I am going to stop here because when we talk about the circle of Willis, the circulation of the brain, and stroke syndromes, that's a very detailed discussion, and we need to be fresh when we do that. So I'll either talk about that after we finish scenarios this afternoon, or on Monday. We'll see where we're at. Again, we're really going to be rushed for time, so I can't spend 5 days talking about neurology. I have to get it done because we'll roll right into endocrine, and then right after that GI, and then right after that urology, nephrology, environmental. We've got so much stuff to get through. So I may try to pick some of this up this afternoon. Sorry, but it's gonna be rough, but we'll get through it. Okay, so let's stop.